Hey doc, this is a class 3 case that you were looking to get some help with. Um, Super interesting case. Let me just start with class 3 cases are more challenging. Not so much challenging in the fact that the teeth are hard to move, but knowing how to ideally get the patient to the best outcome possible. So class 3 cases, we very rarely will get something that mimics the harmony of a class 1 occlusion. Class 2s, we can get much closer to what that harmony might have been. Class 3 is much more difficult. With that said, there are ways to do so. So you wanted to help this patient out. Financial constraints, some TMD, so there's a large drive here. The aesthetics are a concern, but not the primary factor, but more the TMD. And you've astutely identified that the patient's occlusion may or may not be in part due to the issues here. So you had the patient evaluated for sleep apnea. Those results are pending, but I did take a look at the stop bang analysis, and I do think this patient is likely to have probably mild to moderate, probably more moderate, based upon a variety of factors. Large neck, he's male, over 40 years old, scalloping of the tongue, constricted nasal passages on the CAT scan. So the purpose of this video here wasn't so much to talk about that, but anybody else looking at this video, I just want to say this is a patient at high risk for sleep apnea, and it does play a role in what I wanted to share here and how we're going to go about this. So first thing I always do with every clin check, I want to get a sense of the following three questions. What's the molar relationship? What's the canine relationship? What's the skeletal orientation? So molar class 1, canine class 3, skeletal class 3. And again, we have the CAT scan so that we can get a better sense of the truth of that, but I don't think anybody would argue this is a skeletal class 3 case. Skeletally class 3 with a dental class 1. So knowing the difference in classifications between dental classifications, dental class 1, 2, and 3, and then skeletal class 1, 2, and 3, and giving the patient their diagnoses between the two of those is really no different than saying the patient has caries and periodontal disease. We really have to categorize both of those, not just say the patient has oral disease. So I think it's important when we start doing these cases that we get proper diagnostics built into this. So this patient is skeletally class 3. Left side, probably a little bit more normal on the canine. The molars are class 1. Yeah, still class 3 on the canines. There's probably a bolt-in discrepancy here. Let's take a look at what that would be. Yeah, the bolt is not bad. It's outside the view of the screen, but it's 0.5 mandibular excess. So it's not a severe tooth size discrepancy. It's more of a skeletal discrepancy. What does that mean? Well, orthognathic surgery is always an option whenever there's a skeletal discrepancy. This patient denied that opportunity to see a specialist. Without a question, this is a case that can be managed without surgery and have a decent to good, maybe even great outcome with some other modalities. With that said, to cover your medical legal basis, I would still recommend this patient sees an oral surgeon, or at least put in the notes that that was offered to the patient. Of note, the size or the width of this lateral is rather robust. That's actually a good thing considering we want as much upper arch as we can. So we are not going to do any IPR on the upper. Instead, we're going to do some IPR on the lower. That's what this is here. So about 0.3 millimeters between all of the lower teeth in order to get us something close to class 1. I would build in excess overjet here. We very rarely see this amount of overjet when we do this kind of motion. Better problem to have if we have a little bit of it, than to have the opposite problem, which is the anterior teeth end up coupling ahead of time, and we have an anterior interference and a commensurate posterior open bite, which is one of the more frustrating aspects of orthodontics, specifically with clear aligners. So this is how I'd recommend building this in, is about that much overjet. And then you see the patient frequently. Once they get edge to edge, you just see the patient once a month, and then you stop them when you're happy. And then you can kind of fine tune everything from there. I would educate the patient that it's going to take maybe some additional IPR, some enamelplasty of the linguals of the uppers to get things to line up well. This is like trying to force a square through a circular hole to some degree. The patient should know that. This is not as predictable of a treatment modality as fixing a class 1 patient that has some rotated teeth. So that's that. The most interesting thing I saw here, whenever I do a case workup and I give some advice on a case, I'm really thinking about the big picture. If this patient has TMD, what does that mean? Well, the patient has TMD. Well, why? So always asking why always makes us a better clinician, for a couple different reasons. One, if we ask the question why, we have to seek additional understanding about how the system works in order to answer that question, and that additional information that we seek makes us a better diagnostician. So that's number one. Number two, if we understand the etiology of the problem, then we're more likely to treat successfully. So in my mind's eye, this is a patient with high sleep apnea risk, and it's a patient with TMD. And those two things do go hand in hand from time to time. But there's a subset of patients that have TMD because of occlusal issues. I'm not saying this is what's causing his TMD, but I always want to look at the occlusion. So I did a quick run through here, and I looked at the teeth, and I don't see generalized severe bruxism. Maybe some generalized wear, but that wear could be explained simply from his class 3 bite, because it's on the lingual of the lowers. There's just not a whole lot here. With that said, I was kind of moving around like this, and I saw this wear facet, or what could be a wear facet. And this is not a common location to have a wear facet. And then also right here. It's a rather flat surface to a tooth where there's no other signs of attrition, erosion, or any sort of tooth degradation. For that tooth to have that flat surface, I have to surmise that somehow got there from a biomechanical means. But how the heck does a patient who has, let's look at this here, class 1 occlusion, so he's not in crossbite, have that? The buccal cusp aren't going to cause that because this tooth is coupled. The only way this can happen, and it's not something we see very often, but it's something to keep in mind, is if this patient, most likely during sleep, brings his mandible so far to the opposite side. So he swings his lower jaw so far that he goes into crossbite. To confirm that, as you can see, I'm pretty excited about this because this is super helpful information. I wanted to see if there was a wear facet on the upper tooth, and there it is. Right there. So using the iTero software, if you find the right view, it will highlight through the reflection of the artificial intelligence the surface. If you see a large area like this, that means that's a wear facet. As you can see, there's not really any other large areas of white here. You see contact points. That doesn't mean that these are contact points. It just means the whiter the surface, the more reflection there is. And from a vantage point, that indicates that it's flat. So the patient has a flat surface here. You can see it right here. I'm not sure I see, maybe right here when we saw that that lower wear facet. We don't see it on this side. So I'm thinking he slides. I'm not sure where that one comes from. I would just add that to the equation of observations that we see. What does this mean? For a patient to go into that very aberrant parafunctional position where their mandible is going so far to the side, they probably have some sort of sleep issue. Can we say that this is sleep apnea? I don't know. I don't think the studies have ever borne out how the patterns of tooth wear correspond to the presence of sleep apnea or not. This just tells me that the patient probably has more of a severe version of sleep bruxism. And bruxism is what's categorized as a movement disorder. Falls in the same category as restless leg syndrome. So it's very possible that this guy just has a very significant mandibular movement during sleep. This isn't going to change anything, but it changes the conversation with the patient. He really needs something. So if we were to make him a night guard, for example, we would probably make him a night guard that's very flat, where he could grind side to side to give his mandible the freedom to go wherever it wants. That's not the treatment objective here. The treatment objective is to straighten the teeth and then build his guidance in his natural dentition. But if he has sleep apnea, this is just another key to tell us it's sleep apnea that should be treated, because this is another downstream effect. So that's about it. Again, it's an interesting case because of this more subtle, very easily non-observed. Yeah, look at it from this angle. That flat surface there doesn't come from toothbrushing. It doesn't come from anything other than this tooth is interacting most likely with, I'm thinking the buccal cusp here. Let's take another look. I'm sorry, the palatal cusp. Yeah, so I'm not seeing a very significant wear facet here. There it is. Huh. All right. Well, we just answered the question. So, yeah, this patient's going into severe lateral intrusion during sleep, and it might be the reason why he has TMD. He's stressing out his jaw joint. So, a lot of things to manage here. This is a case that I think Invisalign can treat very successfully as long as we know what the treatment objectives are. Definitely get the sleep study done. Bring the patient's attention and awareness to these wear facets, and then let me know what the patient says after all of that. Prepare the patient for the lower IPR, and then get the trays ordered. The last thing I would do, I typically don't move posterior teeth, so I'll actually make the posterior teeth unmovable. I find if I'm not moving posterior teeth, they act more as anchors, and I get better anterior tooth movements. This is an observation. This is not a scientifically proven fact to my knowledge. With that said, if the posterior teeth look pretty good and I have no reason to optimize them, I'm not going to take them from 98% good to 100% perfect. In great part because I'd rather use them as anchors than move them. These teeth look pretty good the way they are. One might argue we could increase the posterior overjet a little bit. Maybe the patient is cheek biting, but it's a concept to keep in mind that sometimes we want to make teeth unmovable to achieve more predictable tooth movement on the other teeth. All right, hope all is well, and keep me posted on the case. Take care.